The older guys in the auditorium might remember a famous US endoscopist by the name of Mike Sivak, editor of a big textbook. And one thing he always said to his students, he told me, what's the most influential procedure in gastroenterology? And the answer is not surprising, it's polypectomy. So right into the topic, polypectomy starts with diagnosis, and Horst will be talking about diagnosis, and Michal will be talking about an update on resection techniques, of which there are many, many, many. Horst.
Thank you, Thomas. Good morning, everyone, again. And first of all, I would like to take the opportunity to thank both Stefans for inviting me. It's always a great pleasure to extend this outstanding conference. So what is the latest evidence and strategies for improvement of diagnostic colonoscopy? Some background information. As you well know, the adenoma detection rate, the ADR, is still considered as one of the most important quality indicators for colonoscopy. And this has an impact on patients' outcome after colonoscopy. As several studies show, there is a correlation between the ADR and the risk of post-colonoscopy colon cancer, the PCCRC incidence. And I show you just one of these trials from the United States, from the Kaiser Permanent Healthcare System, a cohort study, more than 735,000 patients, 2.5 million person years of follow-up. And this graph clearly shows the higher the ADR, the lower the risk for patients to develop post-colonoscopy colon cancer. So therefore, this should be our aim, to increase the ADR. So the ASGE and the ACG Quality Task Force recently summarized the priority quality indicators for colonoscopies, showing here the strength of evidence and the performance target. And as I've already mentioned, the ADR is very well studied, so a high level of evidence, and the performance target is at least 35% in patients who undergo colonoscopy for primary screening, surveillance, or diagnostic colonoscopy. For those with a positive fecal screening test, it should exceed 50%. Other parameters, adenomas per colonoscopy, may be even better than ADR, but it's more difficult to study and to document, at least 0.6. Serrated lesion detection rate, the SSL-DR, should be at least 6% when you do colonoscopy for screening, surveillance, or diagnostic reasons. The Boston Bowel Prep Scale score should be at least 6 in more than 90% of the cases. Cecal intubation rate, 95% and higher, and withdrawal time at least 8 minutes. So how can we reach these targets? What can we do to improve the quality? And here I show you a couple of interventions to improve the ADR. Of course, training is extremely important, but in the interest of time, I cannot extend to this very important intervention. But I would like to go with you through other interventions, optimizing existing resources. For example, second look of the ascending colon, dynamic position change, water exchange, and second observer, the Image Enhanced Endoscopy, IEE, AI, add-on devices, and finally, I would like to report of a new wide field of view colonoscope. So this is just an example how you can optimize existing resources. Second view, either by prograde or retroflected view, as shown here in the ascending colon. Here we obviously detect a polyp hidden behind a fold, and according to a systematic review, including 4 studies, close to 2,000 patients, you can increase the right-sided ADR with a second forward view by plus 10% and by retroflexion plus 6%. You can do either of these techniques. There's no significant difference. So this achieves a modest gain in ADR at the cost of increased procedure time. And the second look is now part of the guidelines, at least in the United States. So what's the impact of IEE? 2 examples: linked color imaging, the LCI for Fujifilm, compared with white light endoscopy, published this year. A meta-analysis, 16 randomized controlled trials, more than 10,000 patients, and you see examples here from our institution on the right side. You can discuss yourself. It is easier to detect this polyp. The results showed that LCI, I would say, moderately outperformed white light endoscopy with a higher ADR, so the risk ratio 1.2, so we increased the chance in the ADR by 20%, and also a higher APC with a mean difference of 0.25. No significant difference between LCI and white light endoscopy in terms of SSLDR and withdrawal time. Texture and color enhancement imaging, what you have already seen here in this outstanding course, TXI compared with white light endoscopy, just published. Meta-analysis, 3 studies, 2 of them randomized controlled, 1,500 patients. TXI outperformed white light endoscopy also to a moderate extent, higher ADR with a risk ratio 1.3, higher APC, mean difference 0.5, shorter withdrawal time. But when you look into details of the study, it's just a difference of 19 seconds. You can discuss yourself if this is clinically relevant. So then, of course, big issue is the impact of artificial intelligence. This is a quite complicated topic, as you well know. We have different applications. The CADe, detection and highlighting of lesions, and I will mainly focus on CADe. Of course, there's also CADx, prediction of histology, so discrimination of lesions, and as we heard yesterday from Jacques Bergman, the use of AI for quality assessment of examination technique and bowel preparation, which is, I think, a very important topic. So CADe, this is an example here showing the cecum with Olympus Avis X1, and you can try to identify lesions. On the left, white light, on the right, TXI, well-prepared colon. Now we switch on AI, and in a second you see the green rectangles showing you 2 suspicious areas. A little bit later, also with the white light endoscopy. And then, of course, you can use now CADx, but I said I will not go into details on this. Here we use NBI for characterization. This is the first lesion with magnification. This is just a lymph follicle, no need for resection, but the second one is a small adenoma, which you could easily miss with white light endoscopy. So what about the results? As we have heard, many randomized controlled trials, meta-analysis. So this is the most recently published systematic review meta-analysis this year of 28 RCTs comparing AI-assisted versus non-AI-assisted colonoscopy, close to 2,400,000 patients. And the results show moderate advantage. So you increase the adenoma detection rate on average by 20%, risk ratio 1.2, and you reduce the risk of missing lesions by half. Also for experts, we see an increase of the adenoma detection rate, 1.19, no difference in terms of sessile serrated lesion detection rate. And the mean adenomas per colonoscopy, also a difference of 0.21. And withdrawal time is a little bit shorter, but I think this is clinically irrelevant. So these are quite impressive results. However, what is not shown in this graphical abstract of the study, but this is shown in more details of the published series, you increase the non-neoplastic resection rate by 39%, and there is no significant difference in detection of advanced adenomas. So this is the efficacy. No doubt that is a relatively high efficacy of using CADe. But what about the effectiveness? This is what is shown in the real world data. So what is in the clinical praxis? And several studies, and I'll show you just one of them, give more information of the effectiveness. So this is studied with non-randomized studies with the advantage we have less operator bias, and CADe use according to preferences of endoscopists. Whereas what I've shown before, in randomized trials, we have a couple of disadvantages: internal validity uncertainty, because it's impossible to blind endoscopists, and also an external validity uncertainty with the highly controlled settings. So this study, recently published, included 8 studies, close to 10,000 patients, non-randomized series, and they showed no significant difference in terms of the ADR, adenomas per colonoscopy, mean of non-neoplastic lesions per colonoscopy, and withdrawal time. So the authors conclude these real-world data question the generalizability of the results of RCTs. So the AGA just recently reported in gastroenterology on living clinical practice guidelines of using CADe for colonoscopy. And the panel acknowledged the efficacy: 8% increase in ADR and 2% increase in advanced ADR and or SSL-DR. However, they could give no recommendation for or against the use of CADe-assisted colonoscopy in light of a very low certainty of evidence for desirable outcomes, showing so far 11 fewer CRCs, 2 fewer CRCs deaths per 10,000 individuals, and undesirable outcomes: more intensive surveillance colonoscopies, 635 more per 10,000 individuals, cost and resource implications. Other interventions. What about the value of add-on devices? Showing here on the right, a procedure with using endocuff vision. And here you see Umbrella, brand new Chinese device with the same concept: flattening folds to provide an enhanced view, prevent slippage during withdrawal, and stabilize the scope tip during interventions. And there are many different devices: cap, endocuff vision, endoring, wing cap, umbrella, and GI colonoscopes. Of course, I cannot go into details, but I would just focus on endocuff vision because this is the best studied technology, EVC. And meta-analysis of 8 RCTs published 4 years ago versus standard colonoscopy showed that EVC moderately outperformed SC with an increased ADR, but the risk ratio just 1.12. And there was a large difference when used by low performers. So may have some value, at least in low performers. Also, a difference in terms of APC, higher APC, and somewhat shorter withdrawal time just by 1 minute. However, after this publication of this meta-analysis, 2 larger randomized controlled trials were reported. I'd show you just one of them. An international series, 10 centers, back-to-back trial, so excellent design, randomization of 717 patients, and the results showed EVC did not significantly improve ADR compared to standard colonoscopy. It significantly reduced the adenoma miss rate just by 12%, and only 4% of polyps missed during the first procedures had advanced features. So if we summarize all what I've just shown, we can refer to a recent publication showing the relative efficacy of interventions to improve the ADR, a network meta-analysis including 124 RCTs, more than 100,000 patients. And the results show a significant improvement in ADR. This was a primary endpoint, and I show you some of these trials. optimizing existing resources. You should take this opportunity. 9-minute withdrawal time, dual observation of the ascending colon, and maybe water exchange. IEE, moderate advantage, iScan, LCI, also methylene blue, CADe, and add-on devices, EndoCap and WingCap. However, no interventions improve detection of advanced adenomas, and only NBI improved detection of serrated lesions. So finally, I would just like to report on a new wide field colonoscope. As you well know, several instruments had been shown in the past and showed significant advantages, but they are no longer on the market. And this is a device on which we recently reported the first clinical results from Pentax with a 200-degree field of view. And you see the difference to compared to a standard colonoscope with 170 or 180, so it's partially retrograde view. And an LED ring surrounds a curved lens protruding from the tip of the endoscope, and other features are comparable to a standard colonoscope. And this is just a short video sequence which we recently published in Endoscopy. And you can appreciate that it's easy to advance the scope because you always see the full lumen. And also we have an excellent view here of the cecum. It's very easy to identify the ileocecal valve. And as you can imagine, it's also easy to intubate. And during withdrawal, we hope to minimize the risk of missing lesions behind folds. Here we are approaching the hepatic fracture. So we can more or less stay in the center of the lumen and have still a good view. And here we identify a small lesion. We have IEE also for this purpose. And for interventions, I use the 1.5-fold magnification, which gives more or less the regular view of a standard colonoscope, integrated water jet. And this allows also, of course, to do interventions here, cold snare resection. So we submitted the data on the first in-human study to endoscopy. It's currently under review, and this is a pilot study, non-randomized, 2 centers in Germany, 3 endoscopies, 64 patients, and quite promising results. So primary endpoint for this pilot study was a cecal intubation rate 100%, TI intubation rate 97%, and you can see cecal intubation time 5.8 minutes. And the polyp detection rate 67%, ADR 44%, which is quite high because 2/3 of our patients underwent colonoscopy for primary screening, and SSLDR 17%. So we hope to proceed to randomized controlled trial. So finally, I come back to my first slide, referring to the PCCRC incidence. And now I would focus on the effectiveness. What is the outcome if you increase the ADR to even higher levels? And this is a very important observational study published by Michal Kaminski's group, and 789 physicians who performed close to 500,000 colonoscopies between 2000 and 2017, and they analyzed the impact of their ADRs on the PCCR incidence. And as you can see here, there is an improvement of ADR over time, statistically significantly associated with a lower PCCRC risk compared with no improvement of ADR, but only among patients whose physicians had a baseline ADR of less than 26%. So this questions, is it really worthwhile? Do we increase ADR to 40, 50, or 60%? This, I think, is not really shown. So my take-home messages: participate in certified training programs to improve the quality of colonoscopy, use only HD endoscopes, use aspirational performance targets, which I've shown, and rely first on basic techniques and optimizing existing resources, and second on ancillary technologies. Consider experts hit ADRs of 50% with no ancillary technologies. So if your ADR is 20% and you increase it to 28%, you are still not very good. So IAE and add-on devices can moderately increase the ADR, and the efficacy of CADe is considered proven, but its effectiveness, performance on real-world conditions is less clear. And finally, you are, of course, kindly invited to come to Düsseldorf in February, and hopefully also to Cape Town for the World Congress of Endoscopy in September next year. Thank you very much for your kind attendance.
Okay, so let's go back to the lecture. Horst, I have two questions. When we hear all of this, we have to do this and this and this, and the final aim is every patient has an adenoma. And then you come with what's new, a real-world study. What's a real-world study? Are the randomized studies performed on the Mars, or are they all biased, or should we stop reading them? So I'm a little bit confused.
But you well know that the randomized controlled trials are to some extent a little bit artificial and do not reflect the real world, because you select patients on selected criteria. Then you cannot blind endoscopists to two different technologies. It's done in highly expert centers, and it doesn't mean that the results are really accepted by the community. And this is, I think, the difference between efficacy and effectiveness. And the effectiveness is finally important for patients' outcome. And this is also shown in your study. This is the real world.
But
that means we need these studies.
Is an expert center a center which is very ambitious to show positive results, or are they really experts?
No, all centers are very neutral. But this is, of course, there's always a tendency. When you get a new technology from a company, then it's always a bias that you want to be involved in studies and so on. There's always some bias. It's very difficult to blind endoscopists, and you have to see, if you just read abstracts. I've also shown you that in one abstract, it was not shown that finally the unnecessary resection rate is so high. Then it's very difficult, and it takes a lot of time. You have to read the whole papers to come to a good conclusion, and this is challenging.
It's challenging, yeah.
Therefore, we need your podcast. This is good because this finally...
Yeah, we're having a podcast here, I think.
Yeah. Can I hop on? Because actually, I mean, Horst, do you think that the difference between randomized trials and those, let's say, observation real-world data studies may be related to the fact that for the CADe to work, you have to have a perfect withdrawal technique. So this may also be a difference, because obviously CADe does not detect if you don't show it on the screen, I mean show the lesion on the screen. So maybe, this is my hypothesis, maybe in the randomized trial the quality of withdrawal technique just was better, so it helped better to spot the lesion, the CADe itself, whereas in real world we have also the problem with the quality of withdrawal technique.
Yeah. This has also an impact, yeah, for sure.
Perhaps.
Perhaps, I mean it's a hypothesis.
I'm not so sure. I think the other factors are also very important. And if you go to so-called expert centers, there are a lot of trainees involved. So people out there in private practice involved in some of the studies, they may have done 10,000 colonoscopies, and in the studies people start at 500. So anyway, so we can't solve this here, but you showed this slide at the end, Michal's slide. So what's the conclusion? It shows that there is a cutoff at 35. There is a recent meta-analysis saying 35, 37. So why increase the ADR? Why spend money if your ADR is 35%? Why? Or shouldn't we rather focus on the low performance?
Yeah, probably the increase to what in some expert centers without, as I've shown in my last slide, without any ancillary devices, they report on a 50% ADR. And we question ourselves, does this really have an impact on clinical outcome? And probably you identify some small lesions, as I'm shown in the video, so tiny lesion, and we don't know if this really interferes with patient's outcome. And this made the background of what you have shown in your study.
And we have tons of data that patients with small polyps have a normal prognosis. And patients with advanced adenomas, which we should help, they have still a worse prognosis. So maybe our problems are somewhere else.
And we have the issue that so far for sessile serrated lesions, the CADe is not very good and not accurate enough. Huh?
Okay, so a little bit more down to earth.
Yeah.
But what will you do in your practice, or both of you? You use CAPs, you use AI. What do you use? Of course, everybody wants to have the latest endoscope generation because it's just nice.
No, I use the existing resources.
Isn't
nice, of course, what I mentioned, high definition colonoscopes, and it's very important to have a PrEP score of hopefully 8 or 9 in 95% of the patients. I think this is important, and to take in your time for withdrawal, to look behind each fold and so on.
PrEP score is not dependent on the patient only. It's also dependent on you, how much time you invest to clean, right?
Yeah,
because the PrEP score are after cleaning.
True. Yeah, that's true. That's true. Yeah.